Hey everyone, good day to all. Today in this video I am going to talk about some hematology important topics. Please stay with me for the 5 to 10 minutes to grab your 2 to 3 MCQs in the hematology. So first of all guys, you have to know the how to interpret the CBC report. First of all, you have to know these values. Okay, so what is MCV? MCV means mean corpuscular volume. Mean corpuscular volume. What does it indicate? MCV means it shows that it tells about the size of the RBC. What is size of the RBC? Okay, and coming to the MCH, it is the mean corpuscular hemoglobin. It means it tells about the juiciness of the RBC. Juiciness means it means it is a hypochromic or hyperchromic. Coming to the red cell distribution, with it talks about the size and shape of the RBC. Size and shape of the RBC. Reticulocytes. It is important to it is important in the differentiation between the erythropoietic diseases. If there is a more reticulocytes, it means there is more erythrocyte production. This is called as baby reticulocytes. Next one, first of all you have to know what is the MCV normal value. It is a 100 to 80 to 100, and the MCH is 27 to 32. So guys, in the first of all you have to see the MCV in the every CBC report. MCV, if it is less than 80, if it was less than 80, it means it is a microcytic anemia. If it was less than 27, it is hypochromic. More than 32, it means hyperchromic. See, okay, now less than 27, hypochromic, and MCV is less than 80, it means microcytic. Okay, see here, microcytic diseases are total 5 types. Microcytic are total 5 types. See, the mnemonic is Sickle. S means sideroblastic anemia, iron deficiency anemia, thalassemia, anemia of chronic disease, and lead poisoning. Sideroblastic and lead poisoning is almost the same. Okay, so if the MCV is more than 100, then it is called as macrocytic anemia. It is a macrocytic anemia. What are the examples of macrocytic anemia? There is a B12 and B9 folic acid and cyanocobalamin deficiency. So how we are going to differentiate between the B12 and B9 deficiency? Okay, so guys, in the B12 it is a iron deficiency. So you will see the CNS symptoms in the B12, wherever in B9 there is nothing, no symptoms. Only here it is the risk of the neural tube defect. But here also we can see that there is a increase in levels of the methyl melanoid coic acid, methyl melanoid CoA acid. Okay, now there is an increase in the urine. Okay, now methyl melanoid CoA. Okay, but here is this value is normal. This is what they will give in the question. Okay, so coming to here MCV is less than 80. You have to differentiate between the sideroblastic IDA, iron deficiency anemia, thalassemia, everything. So guys, for this one, you have to remember one, this sideroblastic, iron deficiency anemia, anemia of chronic diseases. So here is the, in the guys, this is the serum iron levels, and this is the ferritin levels, this is the total iron binding capacity. In the sideroblastic anemia, guys, see, always remember one thing. Ferritin is always inversely proportional to the TIBC, means total iron binding capacity. See, if there is more ferritin, there is a less TIBC. If there is a more, see, always if ferritin is low, if ferritin is high, it is low, high. Okay, so see here, sideroblastic anemia. In the history, they will give that there is a high. Sideroblastic means, guys, it is due to toxicity, due to iron overloaded. If there is iron overloaded, it means everything what? Increase. See, increase. But what I told that if the ferritin is increased, then always TIBC is decreased. Hope you got it. See, sideroblastic means due to it is a iron overloaded. It means more, all are more. So I told that ferritin is always inversely proportional to TIBC. That's why F is T. It's low. Here TIBC is low. Got it? See, for the iron deficiency anemia, it always, see, all low. Always if it low, TIBC is more. Got it? Next, coming to the anemia of chronic disease. So guys, in the question, they will give the history of rheumatoid diseases. They will give the history of rheumatoid diseases. Okay, just mark the answer is anemia of chronic diseases. In this one, there is a low serum iron and there is a more ferritin. If it is more ferritin, then automatically low TIBC. Hope you got it, guys. I think you are listening. Okay, so done. Next one, I would like to talk about what is the Mentzer index. What is the Mentzer index? So guys, Mentzer index, it is used to know whether the patient is having thalassemia or not. So Mentzer index you have to calculate. In the CBC they will give everything. They will give the MCV also, RBC also. You have to calculate something by something. You have to calculate it. If the Mentzer index is less than 13, it means the patient is having thalassemia. The Mentzer index more than 13, it means it is a IDA, that is iron deficiency anemia. You have to calculate this one. Okay, now just remember. And one thing I want to clarify you guys about the iron absorption. See here, see what are the substances that increase the iron absorption? It is a acidic pH and also vitamin C. Acidic pH and vitamin C, they all are helps in the increase in the iron absorption. That's why when the pregnant women whenever they are taking the iron tablets, we doctors always tell to them to take with the lime water. Take with the lime water because it increases the iron absorption. Okay, see what are the substances that increase the iron absorption? It is a alkaline pH, tannins means tea, phytates like sprouts or milk also decreases. Okay, now so this is the one of the exam question also. Okay, you have to remember. So I think I want to clarify one MCQ here also, guys. This is the iron metabolism. See here, when you eat, the iron is in the ferric form. What form? Ferric form, that is Fe3+ form. When you eat, when the iron goes to the stomach, it is converted to the ferrous form. It is the ferrous form by the HCl acid in our body, by the process called a reduction. See, okay na? In the ferrous form, it will enter into the duodenum. Where does the iron absorption take place? In the C. Remember ID, iron duodenum. ID means iron is absorbed in the duodenum. So remember ID. So here iron will go to duodenum. Will go to duodenum by what transport? It is by DMT, divalent metallic transfer 1. Okay now. See, by what transporter? DMT1, and it is stored in the form of ferritin. Okay, what is the transport form of iron? It is called as transferrin. And also guys, when the iron back into the blood, it is in the form of ferric, and it is called as ferroprotein. Okay, now ferroprotein is the one which is going into the blood in the form of ferric. See, ferroprotein, see, this is the ferroprotein. It is inhibited by hepcidin. Inhibited by hepcidin. This is what you have to learn about the iron. Okay, there is going to be one MCQ. Next, coming to some diseases, guys. I choose three diseases for this video. First one is the PNH, that is paroxysmal nocturnal hemolysis. What is paroxysmal? Paroxysmal means it is a sudden. It's a sudden night hemolysis. Okay. See, what happened here is that this is the RBC molecule. In the RBC, we are having the GP1, GPI. It is a anchor protein. There we are having two things here. It is the DAF and MER. DAF and M. These are the CD markers. That is, see, DAF and this is the MER, MIRL. DAF and MIRL. Okay, now DAF it is a CD55 and MERL it is a CD59. These what actually these are doing. These are what the work of the DAF and MERL it is to protect it from the MAC. It means membrane attack complexes. If any antigens coming, if any macrophages coming, okay na, so the work is that to protect the RBC, okay na. It is the both DAF and MER. It is controlled by a gene called as Fmge gene. It is Fmge gene. Okay, so actually what happens here is that whenever there is a mutation in the Fmge gene, then what happens? Will DAF and MER works? No. If they won't work, what happens? Macrophages, antigens and the foreign bodies, they are going to cause the hemolysis of the RBC. Got it? MAC, membrane attack complexes. They are going to easily attack the hemoglobin. Why it is called as nocturnal hemolysis? See, it is called as nocturnal means in the night time, guys. In the night time, there is a shallow breathing. That's why we are going to take less breathing only now in the night time. Because of them, we are having the more CO2 the body. So more CO2 body, it interacts with the water. It called as carbonic acid, and it causes the acidosis. More acidosis, it will be causes the MAC, membrane attack complexes. It will activate it, and then they are going to cause the hemolysis. That hemolysis, this will be breakdown and will come in the morning time as the hemoglobinuria. sometimes it will be reabsorbed in the PCT, and breaked hemoglobins will be stored in the PCT. It is called as hemosideruria. Hemosideruria. It means this is going to be long term. See, hemosideruria, we can't diagnose it we can't diagnose hemosideruria within the see here, if the patient is having hemosideruria, if you find the hemosideruria, it means the patient is already having PNH since 3 months. Okay, got it? If you find the hemosideruria in a patient, it means the patient is having PNH 3 months only, 3 months before only. Okay, now. So for this one, for the screen test, we will do the sucrose test, and for the confirmatory, we will do the flow cytometry. What you see in the flow cytometry, we will see the GPI. See, this is the angle proteins. If there is no GPI, it means no def. Easy to find now. What is the drug of choice is Ukelizumab. Got it? The next one is the G6PD deficiency. G6PD deficiency, which is a XLR. It means occurs only in boys. It is due to the oxidative stress. And also, what are the triggering factors like fababins, sulfonamides, quinine, and also the mental stress. Actually, at the birth, it is asymptomatic. Later, it becoming the symptomatic. What happens here is that this is the hemoglobin. There is we'll see the denatured hemoglobin. This is the denatured hemoglobin of the hemoglobin. Okay, na? That's why the macrophages, the macrophages will come and remove that part. Remove the denatured hemoglobin. See, this is the hemoglobin. This is the denatured. Macrophages come and bite that one. That's why it look like, see. That's why it is called as bite cells. That denatured hemoglobin, it is called as Henge bodies. It is viewed by supravital stain. What is the investigation choice? It is the G6PD test assay, and the treatment is avoid trigger. And the last one is that sickle cell anemia. Sickle cell anemia is due to missense point mutation. Missense point mutation of that is glutamate is replaced by valine at the 6th position. See, glutamate gone, valine welcome. See, glutamate gone, valine welcome. See, it is glutamate by valine. See here, it is, what are the symptoms? These are the bone pain. This is SCA increases the chances of osteomyelitis. But here if the patient is having osteomyelitis and the sickle cell anemia, it is caused by salmonella. Actually osteomyelitis is caused by Staph aureus. But here osteomyelitis with SCA, that is sickle cell anemia, it is caused by salmonella. The patient of sickle cell anemia, they will not get the malaria also. Remember this one. And also, if the patient having sickle cell anemia, there is an increased risk of autosplenectomy. Auto means self-destruction of the spleen also. There is also the priapism. It means long time erection of the penis. And it is also associated with the hand-foot syndrome. It is also asymptomatic at birth, but symptomatic due to, and also it becomes symptomatic due to hypoxia. How you will diagnose it is a CBC. By CBC, there is a increased reticulocytes. Do the liver function test. It will show us more bilirubin. Confirmatory by HPLC, and the drug of choice is the hydroxyurea. Hope you guys got it. This is the part 1. Thank you very much. If you have any doubts, please let me know.